Mm.
Good evening, everyone. I would like to once again welcome you all for this third episode of Investigations in Allergy Practice. As we have witnessed that in the last two episodes of this webinar series, we have discussed about all the basics of allergy history taking and simultaneously the basic of all the in vitro testing. And yesterday we have also discussed about skin prick test, patch test, and then basophil activation test and something which are more advanced things which are expected in near future. So which we have discussed in detail. Now, so today we will be discussing about more in vivo tests which are routinely done at specialized centers. And with me today, Dr. Soundarya is there. Dr. Soundarya M is professor, Department of Pediatrics at Bangalore Medical College, and she is a leading pediatric allergist, and she has just received the Emerging Allergist of the Year Award 2025 in PedAllerCon recently. So, welcome, Dr. Soundarya. Please start the proceedings.
Thank you, Dr. Neeraj, for that kind introduction. Uh, it is a grand finale of the trilogy of investigations in allergy in pediatrics. And today we have four eminent speakers with us. We are starting with Dr. Taha. And Dr. Taha Ashraf, I'm very happy to introduce, is an allergist at the government JLNM hospital at Srinagar. Sir has done his PhD as well. He's a gold medalist with over 11 years of clinical and teaching experience, numerous drug challenges, numerous publications at national and international journals. Sir is one of the no one better to take this session on intradermal drug testing. So, Dr. Taha, welcome. Over to you. Please start your session.
Thank you so much. Thank you so much, ma'am, for very kind words. Am I audible?
Yes, sir. Yes, sir. You are.
I hope I am audible.
Yes, sir. Yes, sir. You're audible. Hello, sir. Sir, you're
Am I
audible.
audible?
Yes, sir.
Yeah,
Yes, sir. You're audible.
yeah,
No
yeah,
problem.
yeah. All right. So, thank you again, Neeraj sir. Thank you, Dr. Sondhya, for the kind words. Neeraj sir, thank you so much for giving me this opportunity to present this topic in front of you. Intradermal testing, indications and pitfalls. That's something what we're going to talk about in the next 20 minutes or so. So, what is this intradermal testing? It's a procedure with which we identify specific allergy reaction to specific allergens by injecting a small amount into the dermis of the skin. Just need to remember that it has to be the dermis of the skin. You can see this angle here. My pointer is towards this syringe. This is where it should go. It should not. This is the dermis. Just the start of the dermis, and beyond this dermis, I mean deep to this dermis, it should not go like the other two syringes on the left side. So, uh, putting this into our dermis, dermis is highly rich in mast cells, and that's where this reaction begins. And then there's a wheel up, and similar to SPT, the reaction is the mechanism, the mechanism is same as that in the skin prick testing, which we've already discussed a day before, and the reading is almost in a similar way. But yes, this test is more sensitive than the skin prick test. You can see on the bottom, it's around 73% of sensitivity in intradermal test compared to that with the skin prick test. So the technique has to be better, though we'll come to that as well. So when did it start? Early 20th century, Lewis and Grant came with this idea that, it was 1926 that this test was used primarily for the diagnosis of tuberculosis to help in that diagnosis. And later on, it got extended to allergy testing as well. This test, though has some controversies, we'll discuss that a little later, but still it holds some value in many areas of allergy diagnosis. And what are the indications? negative skin prick test with a high clinical suspicion of the allergy. If a patient tests negative by skin prick testing, negative by other tests sometimes as well, but there's a huge clinical index of suspicion about some particular allergy in that patient. In that case, intradermal testing offers a great diagnostic aid. And then situations where we come across drug allergies, especially the IgE mediated drug allergies. Intradermal testing holds a good significance, though the utility is dwindling day by day because we have other methods of diagnosing that. But intradermal testing is still comparatively less invasive, and in some classes of drugs like the beta lactams, especially penicillin drugs, then later on in case of the general anesthetics, in case of the local anesthetics, and in case of some other class of drugs, it still holds some great value, which includes some contrast agents as well. Then when it comes to the Hymenoptera venom allergy, intradermal tests is almost the gold standard testing. Then there are some delayed hypersensitivity testing as well, in which the intradermal testing holds a great significance. These tests are coming up. They are on the rise, and the delayed intradermal test reading helps quite a lot in those testing. We'll come into that as well. And autoimmune reactions sometimes can be ruled out by doing typical serum-based intradermal testing as well. So to enhance the diagnostic precision, intradermal testing offers a great aid. And now that when we know when to do it, we should always know when not to do it. Almost same as that of skin prick testing are the contraindications. We know in severe dermographism distress, maybe not is not contraindicated in the sense that it's not dangerous, but it's of no value at all. And if there are some skin diseases where skin is in a condition where it does not react properly, obviously, or we are not able to read the reaction properly, obviously this test is of no use. So not to be done there. Then in case of patients where there is a cardiovascular disease, then there is an uncontrolled asthma as well, almost similar contraindications as that of skin prick testing. Pregnancy again is a relative contraindication, and some part of literature says this is an absolute contraindication, pregnancy, when it comes to doing intradermal tests, except in certain situations of drug allergies. Apart from that, this should not be done in pregnancy. So, and then a history of severe anaphylaxis in the past, obviously, same is true about other tests. And if it's a severe anaphylaxis, we should not do this testing. So the different, when it comes to procedure of skin prick testing, we know, the way we do it in SPT, we prepare the patient properly, we explain the test to the patient, we obtain an informed consent. The consent should be informed. We inform the patient as to, what can be, what can happen, what do we do, and what are the possibilities, though rare, in the possibilities of an adverse reaction, and what can be done about that. So before that, we have already assessed the patient's medical history, and the informed consent has to be written. The patient has to sign the consent. Then it's not just the verbal consent that will matter. It should be a written consent, which is duly signed by the patient, and maybe sometimes an attendant or a witness as well. Then our allergen selection should be proper. Our dilutions should be proper. They are taken up as per the recommended concentration by different allergy authorities like the EARC, like the American Academy, or the END and other guidelines. These dilutions are to be done as per that. Then the technique has to be perfectly all right. We inject a very small volume, around 0.02 to 0.05 ml. This is one of the common mistakes that happens. We inject a lot of it. That should not be done. We'll come to that while we are doing, I'll show you a video as well of the procedure. 0.02 to 0.05 ml, that's the key. This is not more than 2 units of an insulin syringe, which contains 40 units. I mean, something like that it should be. Then a bleb is formed, then a bleb is marked well. The precise angle has to be used. I can show you what is the angle on the, sorry, I got to the previous slide. I'll come to this slide a little later where the angle is shown proper angle 10 to 15 degrees from the skin. That's it. That's how it should be. It should not be more than that. It should not be, anything like 50, anything like 90. That goes quite deep. Then interpret the result after 15 to 20 minutes when you inject. We compare that with normal negative control. We interpret that and we try to find out as to how far beyond the previous wheel did the further wheel go. If that is beyond 3 mm compared to the previous wheel, that's a positive test. Or if it's 3 mm more than that, we need to use these controls, essential controls in the intradermal testing, like the way we use controls in skin prick testing. We have to use controls in the intradermal testing as well. Positive controls is histamine, negative control is saline. The reasons are same. We need to find out positive control. We do to find out whether there is some interference by the drugs, whether there is some interference by the immunosuppressant drugs or the antihistamines or the tricyclic antidepressants and other drugs. Same drug, this curfew has to be applied in intradermal as it is for skin prick testing. I would not go into that detail as been talked about in the previous lectures. Negative control is the saline that actually tells us about if about any hyperreactivity in the skin, baseline hyperreactivity in the skin, because otherwise we can sometimes have false positive results. So positive control, negative control, and then interpreting reactions in comparison to the negative control. The size of the reaction can be interpreted in comparison to the negative control. What happens practically that sometimes you can avoid using these controls if this procedure is previously preceded by a skin prick testing on the same day. If a skin prick test is done and later on same day, same time rather, you use an intradermal test, then doing controls with intradermal testing you can sometimes omit, because positive control, if skin prick testing positive control is validated, then that means you don't need to do another positive control with intradermal testing. And even if and when negative control is also validated, again, you can make use of negative control by a different way. What you can do, usually the reading of the skin prick test is in comparison to a negative control size of the bleb. But then, if you mark the circumference of the bleb, which is found by the antigen properly, you mark that circumference and then wait for 20 minutes. Later on, you see how much beyond this circumference has the bleb gone. That will give you a reading whether if it's gone more than 3 mm, or if the redness has gone, flare has gone more than 10 mm. In that case, the test reading is positive. So, not necessary to give four pricks to the patient of positive control, negative control, because intradermal test is a little painful compared to skin prick test, other prick tests. You can sometimes, if you do a SPT preceding the intradermal test, you can avoid using these, giving these two pricks. So. Then, what are the key considerations while doing this intradermal testing? A right inclination to be used 10 to 15 degrees from the skin, not more than that. Right volume to be injected, 0.02 to 0.5 ml. I told you the concentration of the allergen has to be right. Otherwise, we'll get false positive or false negative results. Concentrations are actually given by different authorities, I said. So right concentration, then the needle has to be, the gauge of the needle has to be right. Between 25 to maximum 31 gauge needle is to be used, not a needle which has less than 25 of gauge, because that would give us, that would not go to the exact side what it's required. These needles work very well, and in practical utility, we have seen that either the tuberculin syringe needle or the insulin syringe needle works very well. With that, it's very easy, very convenient to use. And then right marking of the bleb. The bleb circumference has to be marked. It's not the circumference beyond that bleb is to be marked. Mark the bleb circumference and then go beyond that. Now, this is the diagram. You can see this is the picture. This is the actual. This on the right side. This is the correct way of injecting this 10 to 15 intradermal injection. On the left, you can see other two 45 angles and 90 angle. They go usually, if you use these methods, these usually go beyond this. So the right way and the convenient way is using 10 to 15 degree angle. Then there are some common mistakes that can happen during the procedure. We go to the incorrect depth or volume. Then, sometimes we talked about the medication interference already. Same as that for SPT, those medication curfew has to be exercised. And if we use wrong dilutions, wrong concentrations, our tests can be wrong. And then if wrong timing is used, we maximum 20 minutes. Beyond 20 minutes, we should not wait. 20, after injecting the allergen, 20 minutes, some say even 15 minutes after you should read this intradermal test. I'm playing this video. Let me see. I'm able to play it. Oh my God, this video. Yeah, this is a video where the video which we have recorded at our place working. You can see this is the needle to be used. This is the 31 gauge needle, the insulin syringe needle. You know, see just the 2 units of insulin syringe are used here for injecting. 2 units of insulin syringe means 0.05 ml. Okay, then the bleb is here. You can see the bleb is here. This is the first bleb formed because of the injecting of the allergen. You can see, and then once this is done at the forearm usually, when this is done, then see how do we mark it. This is how we mark the circumference of the bleb. And then after this, we wait for 20 minutes, 15 to 20 minutes. And finally, we check out whether the test is positive or the test is negative. Something over here. This is, we did a lignocaine allergy testing over here. Then you can see on the left side, this intradermal lignocaine 100 concentration was done. This bleb was marked like this. This bleb, the wheel did not come out of this, this was a negative reading. And then once we did an intradermal test with the 1:10 concentration of lignocaine, you can this was the earlier marking, and then you see how much has gone beyond this. So this is a positive intradermal test as far as lignocaine is concerned. So this is how we do this testing, and you know. Everything, all these equipments are to be, I mean, I hope, I rather know that I'm talking to people who are doing this regular allergy practice. I need not to say that a well-controlled setup should be there while we do this testing. The way in a case of SPT, we should have all resistive measures around to tackle any untoward reaction. So that's true for this intradermal testing as well. In the intradermal testing, we have to be more cautious. The chances of reaction are a little more compared to skin prick testing. So, what are the advantages of this intradermal testing? It's higher sensitivity is there compared to this skin prick testing. Then, specific clinical utility is that, this drug sensitivity in some drugs, especially penicillin class of drugs and other IgE mediated based allergies in drugs, this holds great utility. And venom hypersensitivity, hypersensitivity, this is regarded as one of the gold standard tests. Even if the CRD has come up, but that has to be utilized in connivance with this test, then only we go ahead with the immunotherapy decision. Then low level sensitization. Whenever there's low sensitization, we always tend to identify those subtle allergy sensitivities with the help of an intradermal testing. More so when there is a huge amount of clinical suspicion, and even immunotherapy dosing can be guided, sometimes on the basis of the dermal test alone. That's more true about when it comes to the venom hypersensitivity testing. So what are the cons? I mean, the things which are against it, which somehow say that intradermal testing should be used, but we have a heavy heart while doing it. It is a lower specificity, so obviously higher positive, chances of having higher positive tests would be more, and then it's more time consuming and it's more invasive. We know it's more invasive. It's a little painful, to the patient, especially when it comes to drugs, because patient has the local pain for maybe 2 to 3 minutes at least. For that amount of time, the patient gets into a little, a good amount of pain. So painful for the patient, time consuming for us, and the technique has to be very right. So we need to have people who are very skilled in doing it. Then increased risk of systemic reactions is there as well. And when it comes to interpretation, there is subjectivity. There can be variation sometimes in terms of the reaction reading. You see systemic reaction rates 0.7 to 4% local reactions, and systemic is 0.2%, and the local reactions are 0.7 to 4%. A little more than that in comparison to the skin prick testing. This intradermal testing has a value in the non-severe these delayed drug sensitivity reactions like the drug-induced exanthemus maculopapular exanthema reaction. It can have some value. What we do, we inject that recommended concentration of the drug and leave it at 24 hours. Leave it like that. Send the patient home after 1 hour observation. The patient comes next day, sometimes even after 2 days, sometimes even after 3 days, and we find out the diagnostic criteria is almost same. If the wheal bleb has extended beyond 3 mm at 24 hours, or if the redness has extended beyond 10 mm, in that case, this is still regarded as positive. And in comparison to patch test for these reactions, delayed non-severe hypersensitivity reactions, this has some advantages, except for the contact dermatitis where patch test is definitely better. So we already talked about it. It's written here 5 mm, but 5 mm in duration is written here over here, but actually now it's 3 mm as per the 2022 practice parameter update. They mentioned 3 mm only, so we'll go by that only. Then uh, in case of autologous skin serum skin test, we this is actually done to rule out any autoimmune component for a chronic spontaneous urticaria. When this CSU is a it's a frustrating thing for the patient as well as for us sometimes. And autologous serum skin test sometimes gives us the lead. We inject the serum of the patient itself to the patient himself and or herself, and then find out if the wheel is extended beyond 3 mm. And if that is positive, it indicates an autoimmune reason for the chronic spontaneous urticaria, and then our decisions decisions for treatment go accordingly as regards to what is the further course of treatment. So we come to know about that time whether it's an autoallergic urticaria or it's an autoimmune urticaria in that case. So sometimes, not sometimes, the preparing the SPT antigen, whenever we use SPT antigens have to be prepared, they are actually prepared primarily based on testing sensitized individuals intradermally, and their concentration is made on the basis of that only. And in fact, the arbitrary, these biological allergy, BAU or BEU, they are described as per those serial intradermal testing in the sensitized individuals. That's again a great utility of those, but that's for the diagnostic part, not for our clinical use. And in the era of more sensitive techniques in the present world, like specific IG, like CRD, this intradermal testing still holds its ground. Why so? There has been a study recently, 2021-2022 publication. 57% more patients were identified by intradermal testing where SPT had missed them. Almost 8.6 times more reactive allergens compared to SPT. This study indicated. The study was this. This was a study done from US. 371 patients were tested and were tested by intradermal, and in all these patients, SPT had tested negative, but intradermal testing showed us the way. They tested positive for fewer allergens, and at the end of 4 years of immunotherapy against those allergens which the patient had tested negative on SPT and positive on intradermal, all these patients reacted. There were 371 patients. All these patients responded very well to that immunotherapy. So the intradermal testing in these patients showed us a great lead. And obviously, we need a holistic approach, integrating these all tests, specific IG, CRD, SPT, and finally the intradermal test, whenever required, needs to be done. There are three cases on the right bottom side. You can see negative skin prick testing, and this is the real world scenario where this intradermal testing holds good value at present. Negative skin prick test, positive intradermal test, we already talked about. Then drug hypersensitivity. Drug hypersensitivity is a great value in case of IG-mediated reactions. And venom allergy, I'm repeatedly saying this is still regarded as the gold standard. This is the paper, and we need to standardize intradermal testing procedures, though. These are the different ways we can standardize it. We can standardize the allergen extracts first. That's true about SPT and now intradermal as well. Then we can make uniform dilution protocols, and not only protocols to make proper right dilutions, right concentrations, but also to avoid any kind of contamination, infection, and all that, and follow that US Pharmacopoeia 797 set standards. That's really great if we can have that in our setups. That's not a big deal to do it. I can share those protocol PDFs if somebody wants them. Then consistent injection and reading. This AI can have a great role in this. This to have a consistent injection and consistent reading. AI can help us in that, whether the injection was right, whether the reading is right. So these tools can be utilized and check out whether everything went well, so that our results are more validated and more uniform. Then adhering to professional guidelines, we already talked about them. This is the future direction research, almost same as we earlier talked about. Needs to integrate all those things, all those these methods to diagnose different types of allergies. So takeaways: a valuable tool. Intradermal testing is in specific context. We talked about those contexts. Then proper technique, proper controls to be used. Controls can be avoided even sometimes. As I told you, there's a tricky way to do it. Then we need to balance its sensitivity and specificity depending on the situation we are into, where we are actually landing into. And obviously, in the modern allergy practice, it still has a good role. Though we thought it may have a not as great as a role as it was in the past, but still it holds good relevance. Thank you.
Thank you, Dr. Taha. That was a lovely and enlightening session. Thank you so much. Dr. Taha, you will be there till the end, or should I take your questions now?
Yeah, sure. I'll be here.
Okay. Then I think we'll proceed as per schedule with the next session. Our next session is by Dr. Karthik Nagaraj. Dr. Karthik, you are there?
Yes, I'm here. Yes.
Okay. So, Dr. Karthik, it's such a pleasure to introduce you. Dr. Karthik is a pulmonologist who has the ERQ certificate in with excellence in allergy. Sir has been currently the head of the VN Allergy Asthma Research Center in Chennai. He has numerous publications, national, international journal. He has authored several chapters as well with 10 years of experience to his kitty. So with this, I request Dr. Karthik Nagraj to kindly proceed for the session on nasal and bronchial provocation tests in clinical practice. Over to you, sir.
Thank you, ma'am. I'm sharing my screen. Is this now visible?
Yes, sir, it's visible. If you just go to slideshow, it should be good. Yes, we are good. We are good to go, sir.
Perfect. So thank you so much, Soundara ma'am, for the introduction. Thank you so much, IAP Allergy and Immunology chapter, for the invitation. Here in this initiative where we're discussing about allergy testing, we've been looking at covering all the aspects of in vivo, in vitro tests, and when to use which tests, and how to implement, interpreting, and trying to overcome some of the complexities associated with some of the tests. My job here will be to talk about how we can use these tests like nasal and bronchial provocation tests in our routine clinical practice. What are some of the issues that we can face, and some of the future trends that we might be able to overcome. So I'll begin with the case scenario. This is a patient I just had 7-8 months ago. We treated her. 16-year-old female with allergic rhinoconjunctivitis who is a moderate to severe persistent rhinitis. And she had perennial symptoms with monsoon worsening, both indoor and outdoor symptoms were present. She had the typical allergic rhinitis features on examination, even conjunctival redness and papillae were present on examination. And investigation showed a total IgE and she presented to us. After stopping antihistamines, we did a skin prick test which showed multiple allergens or aeroallergens were positive, including your dust mites, your dermatophagoides, staphylococcus parinae, bromia, your alternaria, and your parthenium and cockroach are also present. We subsequently did a specific IgE, and that also turned out to be almost all the allergens turned out to be quite significantly positive in this patient. So after a detailed discussion, because of the straightforward case scenario, although there is polysensitization, there was a strong positivity, and even pseudopodia were noticed in the skin test. So we went ahead and gave a trial of subcutaneous immunotherapy to the combination of TPDF and Blomia in this patient. She was compliant to therapy. She took it for 6 months, and the initial month she had a very significant total nasal symptom score, which is one of the important objective scores for patients' nasal and ocular symptoms. And within the first month, she had an improvement in her symptom. But by month 3, her total nasal symptom score started worsening, and by month 6, it was almost back to her previous baseline. And she was already on daily antihistamine use, and she had initially improved, but then again recurrence in symptoms. They were worried, and therefore we decided to proceed with a component resolved diagnosis. And in the component resolved diagnosis, we picked up several things, and we'll discuss about this particular scenario down the line. However, despite component resolved diagnosis, we realized that this patient had both the alternaria primary sensitization. That particular picture is currently missing in this. However, alternaria alt A1 was also significantly positive, in addition to DERF2, and also there was also your arginine kinase DERP20, BLAG9, which was also suggestive of your cockroach sensitization. Blomia, incidentally, was only BLOT10 positive. Therefore, we decided that Blomia was probably not going to respond to treatment. So we decided to proceed with certain another way to find out is alternaria significant or not. Should we really relook at immunotherapy? Is the immunotherapy content wrong? Is there a minor allergen positive, or is the content of antigens in our immunotherapy wrong? All these were also considered, but a possibility of allergic rhinitis, not probably just sensitization, but possibility of considering for alternative immunotherapy was looked at in this patient. We'll look at that a little down the lane, but this is just a common scenario. Sometimes if you're doing allergen immunotherapy practice, you are going to come up with patients with polysensitization where decision on immunotherapy becomes a little difficult to take. So we know that allergic airway disease is a heterogeneous condition where there is immune-mediated and non-immune-mediated condition, where predominantly now we have classification into both a T2 and a non-T2 inflammation. And among a set of these T2 inflammation are the truly allergic diseases, and predominant inflammatory conditions of the allergic airway diseases are your non-allergic disease conditions. And you can include your chronic rhinitis and your asthma and even your conjunctivitis fall under this group, where they can be subdivided into allergic and non-allergic phenotypes or endotypes. And even from the allergic, there can be somebody who is atopic, who is called as atopic respiratory allergy, and who tend to be non-atopic, who are called as local respiratory allergy. And a combination, sometimes the patients can have a combination of an atopic and a non-atopic allergy, which is what is called as a dual respiratory allergy. So these are the newer things being discussed nowadays and this has been in discussion for nearly 6-7 years already now. And we'll probably take these are now the newer thoughts in endophenotyping rhinitis patients. So this is a picture where, it's a very busy slide, but, it's very simple. I'll just explain it. The antigens, when they're present, they stimulate the, innate dendritic cells. And then based on that, there is a class switch from an IgG1 mediated to an IgE mediated reaction. And this IgE goes and binds to the Fc epsilon receptor on the mast cells and the basophils in the mucosa. And after saturating the mucosal lesions, mucosal cells, they then end up spreading through the bloodstream, and therefore they present after saturating the respiratory or the mucosal basophils and mast cells. They are present in the serum levels. So there could be a possibility of something called as a local respiratory allergy, where the IgE is present in the mucosa, respiratory mucosa, or bound to the mast cells or the basophils, but their systemic presentation in the serum levels are absent. So local allergic rhinitis is an important phenotype of your chronic rhinitis patients, where it includes local allergic rhinitis and local allergic asthma. This presents with chronic nasal symptoms when the atopic testing, such as your skin prick testing or specific IgE, may be negative to such patients. This is commonly seen predominantly in females, patients who have a family history of allergic rhinitis or asthma, who have a severe nasal symptoms, and who have an earlier rhinitis onset. The newer concept that is looked at in this group is that most of the children start with a local respiratory allergy and then proceed becoming an atopic child data. So some of the patients who actually present who have been evaluated in multi-center studies have shown that nearly 45% of the patients are labeled as allergic rhinitis when they present with chronic respiratory symptoms, and 24% of patients are nearly local allergic rhinitis after undergoing certain provocation testing. Nearly 12% of patients are also dual allergic rhinitis. So nearly 35 to 37% of the patients are nearly missed by your routine SPT or specific IgE based testing. And after complete evaluation, some of the papers have shown that previously when non-allergic rhinitis was initially thought of at 45% as their incidence, after nasal provocation testing or appropriate testing, they were relabeled into only 18% of the patients who were ultimately non-allergic rhinitis. So why do we need to do provocation testing to pick up these kind of situations? Provocation is nothing but a functional test where we are recreating the exposure, but in a controlled manner. Whatever happens in natural exposure, that is being recreated. But we are looking at, after taking a detailed history, we undergo sensitization tests. And ultimately, after doing a provocation test is when we can say with certainty that we have achieved a diagnosis. So to confirm a diagnosis, the provocation test is your gold standard technique. And it is also useful in validating your in vitro tests, such as your specific IgE. All your methods of specific IgE are validated based on your nasal provocation test based diagnosis. Your ability to identify allergen triggers, wherein you can use it either for a preventive therapy like adopt new lifestyle changes, house, pets, hobbies, or therapeutic aspect where allergen immunotherapy is also decided based on a provocation testing, where it is considered as a gold standard technique to decide allergen immunotherapy in patients with airway allergies. The success of an allergen immunotherapy is also predicted, particularly in patients with polysensitized individuals, the kind of scenario that I just presented earlier. And these are all patients in whom we can decide whether their immunotherapy is going to probably work or not, even before starting therapy. You can also identify the allergen threshold for reactivity. This can be used as an excellent follow-up tool, as in the patient started on allergen immunotherapy and earlier they were extremely sensitive, and then we can look at it down the lane, like maybe a year or so, and then repeat your nasal provocations to look at what their threshold has improved or not, and also to identify the efficacy of all your anti-allergy measures, including your pharmacotherapies, your intranasal steroids, antihistamines, combination of medications, all your anti-allergy products like mattress covers, masks, purifiers, all have been used by looking at your provocation testing. So if you remember the title slide, there is actually a allergen chamber where patients are exposed to cat. They are cat allergic patients. They are exposed to the cat dander, but the efficacy of the air purifier was looked at in that particular picture. Incidentally, you can also use these provocation testing for occupational exposures and also use it for a dose finding protocol for allergen immunotherapy, especially in the phase 1, phase 2 studies for allergen immunotherapy in products. So there are several methods of provocation. The most common ones that we will be discussing are your nasal provocation and your bronchial provocation. We will briefly touch upon what is conjunctival provocation. So the nasal provocation is where we will look at by directly stimulating the nasal mucosa in a controlled manner. So there are several indications why we go about it. This is one, to establish a diagnosis where there is a discrepancy between the symptoms and atopy test. Patient is having a lot of atopy, specific IgE or SPT positive, but symptoms are not strongly positive, or patient is extremely symptomatic and their atopic tests are coming very mild or not matching with the symptoms. Where there is a suspected local allergic rhinitis also, like for example, a patient is having negative SPT or specific IgE, but highly symptomatic, and symptoms are classically suggestive of allergic rhinitis. Where the possibility of a dual allergic rhinitis needs to be established also, we need to use this scenario, or where patients with occupational allergic rhinitis. As a therapeutic decision, it helps in deciding allergen immunotherapy selection, especially in the polysensitized patients, and also as a monitoring tool, especially after starting immunotherapy, based on for your allergen immunotherapy phase 1-2 trials. So there are several contraindications for the test. Before we proceed, we should know that this should not be performed in patients who have an underlying acute inflammation of the nose or paranasal sinuses, those who have undergone a recent nasal surgery with less than 4 weeks, or those who have underlying severe asthma or uncontrolled COPD who have a FEV1 less than 50%, are definite contraindications for them. procedure. Those who have underlying severe comorbidities where beta blockers usage is present, where in the untoward circumstance when they develop a systemic reaction where adrenaline or epinephrine cannot be administered, pregnancy again becomes a contraindication for the procedure. There are several measures that we need to take before we proceed. First things would be the washout period, very similar to your skin prick testing and intradermal testing and other tests that have already been discussed, that since this is an in vivo test, we need to avoid topical medications and the systemic medications. For the washout period is already mentioned. There is a guideline which also mentions how much is the washout period. Mast cell stabilizers, which is not commonly available in India, need to be stopped for longer periods of time. Systemic corticosteroids, long-term use, more than 6 weeks, should be stopped for at least 2 to 3 weeks before administration. And if the patient is on leukotriene receptor agonist, there is a difference in the recommendation. However, YACI recommends no recommendation for stopping leukotriene receptor antagonist, and the American recommendation says to stop leukotriene receptor antagonist for at least a week before proceeding. So what is the timing of the test? So can we do the test any time of the day? No. We need to look at it. If the patient is having a seasonal allergen is being tested, the test has to be performed outside of the pollen season to minimize the exposure outside of this particular controlled environment. However, if it is a perennial allergen, you try to do it at the time when the exposure is minimal allergen exposure is present. This is particularly seen in patients in daytime outside of their home when they have not had any exposures, or when their symptom burden is on the lower end, particularly during the summers or in the early spring, can also be looked at for perennial allergens. A prerequisite would be, prior to proceeding with a nasal provocation testing, would be to confirm with an SPT and a specific IgE that there is no sensitization in these patients. A nasal endoscopy is recommended to identify if anatomical issues are present, which can hinder the provocation test. But this is not recommended on the same day of testing. It should be done a day or two prior to testing. A PFT is must to identify the FEV1 value so that you can identify asthma and therefore take necessary precautions. The patient should be able to follow instructions, and the test has to be done in a setup where you're able to manage systemic reactions when they do occur. You need to have a trained staff and a trained doctor. There is a small learning curve for performing nasal provocation testing, and it is not recommended to be performed in routine clinic settings unless until you have a backup for management of reactions. So what are the allergens and the extracts you can use? The difference here comes when you can say that, okay, you cannot just take any allergen extract that you have commercially available in the market and then directly instill into the nose. The recommendation here is because some of the extracts that we have are glycerinated extracts. So the glycerinated extracts are capable of causing an irritant reaction by the glycerinated product itself. So aqueous extracts are recommended, but aqueous extracts have a short half-life, and therefore when you purchase aqueous extracts from the manufacturers, you should be able to use them immediately, or when you prepare them, dilute them according to the testing. You should be able to use them within a short period of time. So grouping your nasal provocation testing is sometimes recommended when you're performing for many patients together. In the European Union, there are standardized extracts for nasal provocation testing, but currently they're getting withdrawn. In the USA, they don't have standardized extracts. They directly purchase it from the manufacturers, and this purchased item is not considered US FDA approved because no studies have been done. Test solution should be isotonic and pH neutral, because the salinity and the pH can itself cause irritant reactions and false positive reactions. So there are no standardized dose or concentration that has been studied, but there are some recommendations available. We'll read about that down the lane. This studied units, or the allergen units, varies by the product and also by the manufacturer and from the countries. So there is no strong recommendation as to this is the milligram or this is the unit to be used for each allergen as of right now. So how do you prepare your allergen preparation? You should use aqueous extracts. There are several methods in doing it. The one that is most famous right now and being used everywhere is the Stephen Durham's recommended protocol that is being followed throughout Europe and also in India right now in selected centers. Here they use the 12SQ HTM slit tablets, which are arbitrarily labeled as equivalent to 30 units, 30,000 units, and there are no measurements as to how many units it contains. But based on that, they are further diluted into 6 further dilutions, and these are also into every double dilutions or triple dilutions, and they're labeled with arbitrary units. When there are standardized extracts available in the absence of this particular technique, such as when you're in Europe or whenever you have access to standardized extracts, you can use 10 times dilutions of the SPT concentration, sometimes going from 10, 100 and 1000 dilutions of the SPT extract can be used. However, we need to remember that the glycerin content of these extracts can interfere with your interpretation. So YACI 2018 guidelines actually does not give a single dilution or a strength has been recommended yet by YACI for preparation of your allergen extracts. And it is not recommended using non-standardized extracts such as your cockroach or aspergillus, or for your not standardized extracts of pollen that are routinely available. So for diagnosis, a single concentration is considered sufficient. You need not use multiple dilutions. You can prepare safely one is a 100 dilution of a standardized extract which is available, and that can be instilled, and that should be sufficient to establish a diagnosis. If you wish to, in the patient who is extremely sensitive individual, you can go with a much lower concentration like 1000 or 10,000 dilution, are also recommendations from YACI. So this is based on this particular recommendation of Stephen Durham's is based on this study where they found that if you use in atopic individuals who are dust mite or a silver birch positive patients, they found that having a concentration of 100 AU or 500 AU, they were able to significantly produce a drop in the peak nasal inspiratory flow, which is considered standardized. We will discuss about that. So based on this study, the recommendation is for how to use your 12SQ HTM tablets can sometimes be used for dilution preparation. So there is a methodology on how to go about applying this particular extracts also. There are several methods in applying. One of the most famous is the nasal spray technique. We can also use what is called the micropipette technique or the filter paper technique. The patient is allowed to acclimatize to the room temperature for 20 to 30 minutes, where a baseline measurement is taken where for your total nasal symptom score or your visual analog score, and a basal peak nasal inspiratory flow or an acoustic rhinometry or rhinomanometry measurement is done. And then 10 minutes later, a repeat measurement is taken. Then they instill your negative control, which is actually your diluent which is present, either it is normal saline or the diluent that is used for your allergen extract, and then that will be your first measurement. Once your negative control is measured, every 15 minutes we can instill the lowest dilution of the extract, 0.01 ml or 100 microliters. This is 0.1 ml, 0.01 ml in each nostril at the inferior turbinate is recommended. And 15 minutes later, we have to measure the TNSS visual analog scale or the method that is used for measuring the objective flow. So this is the Aptar 2-dose nasal spray that is commercially available in Europe, which is used by most centers across the world for instilling and preparing and instilling the nasal extracts. They are first diluted into different concentrations based on the different allergens available, and you choose the inferior turbinate as your target and instill 100 microliters either through a nasal micropipette or using your nasal spray, and then you apply 100 microliters on this nose and 100 microliters on the other nose also, and wait within the next 15 minutes to take some measurements. So what are some of the measurements you take? You take a subjective measurement and then you take an objective measurement. In the subjective one, we look for the symptom scores, where we include the total nasal symptom score, which is composite of sneezing, rhinorrhea, congestion, nasal itching, which ranges from 0 to 3, mild, none, mild, moderate, and severe. And it also can include your ocular score, like your redness or watery eyes, and a sum total of either 12 or 18. If you're using your ocular score, you can use an 18 score. In addition to this, it is also recommended to do a visual analog scale measurement where the patient is told how do they feel overall with regards to sneezing, runny nose, congestion, and they make a mark on the scale ranging from 0 to 100. So when we say 0 to 40, it is considered a mild reaction. 40 to 70 is considered a moderate reaction. And anything more than 71 and above is considered as a severe reaction. So there are several objective measurements also taken. We use what is called as a peak nasal inspiratory flow. This is a simple bedside tool which can be added. This is actually opposite to your peak expiratory flow, where you place a mask onto the nose and create a good seal around it, and ask the patient to take a deep inhalation through the nose and not through the mouth. And on inhalation, the marker moves from 0 to above, and that will be the peak nasal inspiratory flow. 3 readings are taken, and average of the 3 readings are taken as a measurement for that level, and they're repeated before and after administering your local your allergens. You can also use what is acoustic rhinometry and rhinomanometry. These are tools available only in advanced ENT centers. The places like in Europe, they use predominantly acoustic rhinometry, where the volume of the nose occupied. This is a long tool that measures the sound waves that passes across the nasal cavity and comes back, and therefore the cross-sectional area of the nasal cavity is measured in both noses, and then it measures the change in the cross-sectional area across the two ranges. Rhinomanometry measures the pressure difference between the anterior and the posterior location of the nasal cavity, and the pressure difference is also looked at for evidence of nasal congestion or decreased nasal flow. So after doing this test, there are certain positivity criteria which is mentioned by the YACI guidelines. They say that you should use a combination of subjective and objective measures, and if you have a change of more than 23 millimeters on VAS, it is considered moderately positive. Symptom score more than 3-point change is considered moderate, and more than 5 is considered strongly positive. If you use a peak nasal inspiratory flow, the flow decrease by more than 20% is considered moderate, and more than 40% is considered strongly positive. So to say a positive nasal allergen challenge, you need to have a strong objective or a strong subjective, or one moderate or one moderate objective and subjective symptom to be present to label as positive nasal allergen challenge. So to the patient that we had discussed earlier, we actually planned for nasal provocation to see will this patient benefit with alternaria. But before that, we wanted to check if whether dust mite will work in this patient or not. And we did a nasal provocation testing, and there was a significantly positive change in the nasal provocation to dust mites. And 1 week later, we repeated it to alternaria, which turned out to be negative. And therefore, we realized that alternaria sensitization was irrelevant in this patient. And because we used the 12SQ HTM split dilution in this patient, we switched to the therapy, because whatever we tested, we gave that for treatment. And now the patient is on 4 months of therapy. The TNSS is now better, and the patient is currently doing well. So there are several safety and reproducibility issues when it comes to nasal provocation testing. The safety is that it is especially in nasal and conjunctival patients, rhinoconjunctivitis patient is extremely safe. Other than in asthma, who have an FEV1 less than 70%, the chance of a systemic reactions are very, very low. We are yet to experience any systemic reactions in our patients. We can use both an aerosol spray and a micropipette, which are equally good in producing results. Symptoms are usually non-troublesome, which can be immediately recovered by giving your antihistamine or topical therapies, or very rarely some paracetamol for headache or congestion is required. Late reactions are possible, but these are very rare in the testing. The reproducibility is that if you use acoustic rhinometry, has got the best reproducibility. It is an expensive tool. It is not available in all centers across the country. The concordance is that nasal spray and micropipette are able to produce in equally same amount of reaction irrespective of the method used. Presence of asthma does not alter the reproducibility, because nasal inspiratory flow requires presence of a good airflow, bronchial airflow through it. So presence of asthma does not alter the reproducibility of the symptoms. You need to have at least 1 week time difference between 2 successive nasal provocation testing, or between a nasal or a bronchial provocation test. There are several false reactions, like false positives or false negatives. I'll just briefly mention that the irritant reactions due to impurities like glycerin, irritant pH less than 5 or more than 8, faulty delivery, if you don't apply it adequately, you'll get a false positive reaction. If you don't have a proper nasal hyperreactivity control, like using or your diluent or normal saline. If it's not used, it can produce multiple false positives. False negatives are possible when the patient has exercise nasal polyposis, which is preventing application of the allergen into the nasal mucosa. Medication washout period is not considered. If the nasal obstruction is present, or if too low concentration, if you not use the proper standardized allergen extract, that might produce a false negative reactions. So where can we apply nasal provocation testing? Actually, there are studies have shown that you can identify local allergic rhinitis phenotype, and especially patients who have a negative specific IG or SPT to aeroallergens, but their symptoms and clinical manifestations are typical of local allergic rhinitis. And they have shown that in children, the prevalence of local allergic rhinitis is quite high in the West, but it is quite low, maybe because it is not yet studied in Asian children. HCM is found to be the most common allergen responsible for local allergic rhinitis in Asian children. So there is also predictor of response, and within 1 year of follow-up, improvement in the subjective and objective scores on nasal provocation are studied with both HTM and Birch. And you can choose your allergen immunotherapy in polysensitized patients, especially like the patient that we had in our scenario. Briefly, we'll talk about bronchial provocation testing. Similar to your nasal provocation test, we can provoke the bronchus, but bronchus is a little lower airway. Airway hyperresponsiveness is considered the hallmark of asthma, and this is especially indicated in demonstrating airway hyperresponsiveness in athletes who are prone to get exposed to cold temperatures like winter sports. When there is a diagnostic dilemma, patient is symptomatic, but all tests are coming negative, including a spirometry or impulse oscillometry are negative. So you can go ahead and do a provocation testing to establish airway hyperresponsiveness. If the history is suggestive of asthma, but baseline spirometry is normal, occupational asthma is an important tool, or in evaluating response to therapy, especially for inhaled corticosteroids, biologics, or allergen immunotherapy when used in a research purpose. So there are several types of testing. You can use a specific bronchial provocation test by choosing allergens which are suspected, or you can use what is called as a non-specific bronchial provocation testing. So for the non-specific bronchial provocation is what we will focus on, because there's not a lot of standardized data on how to use specific bronchial provocation testing in population. Prior to that, we need to know that poor lung functions or inability to perform acceptable spirometry, recent stroke, or other contraindications for spirometry are also absolute contraindications for proceeding with bronchial provocation testing. So the non-specific bronchial provocation test here is by just creating airway smooth muscle contraction, there will be a drop in FEV1 from before to after. You can use what is called as a direct challenge, where directly by acting on the muscarinic receptor or histamine receptor, methacholine or histamine produces a direct bronchoconstriction. Here you use what is called as provocative dose, which causes a 20% decrease in FEV1 before and after administration of your direct challenge. There are classification criteria to say how sensitive they are based on the dose required to produce a 20% drop. So after you administer, depending on the dosages, you see that there is a drop in the FEV1 with time, and the dose which produces a 20% drop in FEV1 is considered as your significant value, and further testing is not required. So similarly, you can also challenge the bronchial mucosa by an indirect challenge by giving through nebulization. There are mannitol capsules available which can be prepared. Otherwise, you can use certain techniques like eucapnic voluntary hyperventilation. Our patient is asked to voluntarily hyperventilate for close to 5 to 6 minutes if possible, or to exercise on a treadmill to reach a heart rate of more than 85% of their target, or their maximum voluntary ventilation of more than 60% target if they reach. This is the ideal time to see whether there is a change in FEV1 with indirect challenge. How indirect challenge works is by working on the intermediary cells like leukocytes and neuronal cells, and therefore that indirectly produces an airway smooth muscle, bronchial endothelial cells, and secretory cell activity, and that ultimately leads to airflow obstruction. The criteria used in indirect challenge is a 15% fall in FEV1, where in mannitol we look at the dose which causes a PD15. So there are different gradings for a mannitol challenge, where if the dose is more than 635, it is considered normal. Less than 35 is considered severe bronchial hyperreactivity or airway hyperresponsiveness. So bronchial allergen challenge test has been looked at, and it was the method to diagnose allergy or allergic airway disease prior to your newer tests like your in vitro tests before they became available. But whenever there is an allergen exposure, there is both an early allergen response and a late asthmatic response. And this is seen predominantly with pollen, which produces an early response, and house dust mite are capable of causing late responses. So this bronchial allergen challenge is useful in patients where there is a suspected isocyanate or inhalant-related occupational asthma, like Baker's asthma, wheat-related exposures. Such kind of scenarios, bronchial allergen challenges are present, but there is no data yet which suggests what is the appropriate dosing regimen for performing your allergen challenge in such conditions. So it is used in research settings where you're trying to assess the phase 2 trials for validating extracts. A 2 days exposure is required. Day 1 with placebo, where you rule out that there is no spontaneous responses to your saline or air inhalation. Day 2 is with the allergen exposure, which produces a positive test. The drawbacks is that it needs to be performed only in specialized centers. There is no recommendations on protocols. There are no standardized protocols available, and there is a risk of systemic reactions. So this is what I was showing in the title slide, where there are allergen exposure chambers available, where the patients and multiple patients who are both controls and healthy patients are kept seated inside a large room, which with controlled settings of temperature, humidity, and they're able to give the allergens through the vents in the air. And this produces a systemic allergen exposure, and they monitor the nasal, conjunctival, bronchial symptoms. They keep reporting their symptoms on these iPads that are given there, and this is useful in allergen immunotherapy studies, where dose finding studies are useful. This helps in determining whether which dose of allergen immunotherapy is effective in reducing the symptoms of on exposure. So this is expensive. There is limited availability across the world, especially in Japan, and most of the centers in Europe have an allergen exposure chambers. Briefly on conjunctival allergen challenge, this is very similar to your nasal provocation testing, where the conjunctiva, the lateral canthus or the lower eyelid is exposed to the suspected allergen. The dilution extract preparations are very similar to your nasal provocation testing, and after test you can look for whether there is a strong positivity or a mild positivity based on the conjunctival redness, itching, tearing, chemosis, or lid swelling. So there is something called as a total ocular symptom score, and sometimes some of the polysensitized patients can undergo allergen testing to identify the ideal therapy for them, or also as a good tool. There's a grade A recommendation to use allergen immunotherapy, conjunctival provocation, to look at the allergen immunotherapy efficacy because of its extreme safety profile. There are very limited systemic reactions and not reported in most of the conditions. This is a paper where they looked at patients with rhinoconjunctivitis and Lolium perenne. They had allergic rhinoconjunctivitis, and after giving immunotherapy to Lolium pollen, they found that after using a conjunctival provocation, they were able to say that most 60% of the patients had improved reactivity after starting immunotherapy for 1 year. So now this brings to a concept: can we use one challenge for testing for a disease in elsewhere? This is what is now the concept looked at, what is called as your United Airways disease concept, extending from the nose, eye up to the bronchi. And there is a link between the two, either through neural reflexes between the conjunctiva to nasal mucosa to the lung, parenchyma and bronchi, and also by mediator release, which also spreads from eye to the nose to the lung also subsequently. So there was a thought process which looked at whether can we replace the specific organ by testing elsewhere for challenge. So the nasal provocation testing actually produces a drop in nasal and bronchial volumes, and conjunctival provocation test also produce nasolacrimal duct obstruction and nasoocular reflex are also present in these patients. So they also noticed that there is a similar inflammatory mediators present in the eye, nose, or lung in the absence of underlying rhinitis or even asthma. So they started looking at whether conjunctival provocation test can be used as a surrogate marker for allergen immunotherapy for allergic rhinitis patients, and also whether nasal provocation can be used for asthma patients. So this is where the paper actually looked at in patients with HTM sensitized asthma, nasal provocation actually and bronchial allergen challenge were strongly correlated with nearly 83 to 90% of the patients. So it could be integrated in the diagnostic algorithm of HTM-driven allergic asthma ahead of prior to choosing patients with polysensitization also. So what are some of the future directions? Can we use in vitro alternatives to provocation testing? Can we take nasal secretions and test IgE antibodies? This concept has been known actually from 1947 itself. But from 1970, they demonstrated that IgE antibodies are present in the nasal secretions, but there are no validated methodology or cutoffs available. There is a lot of variation in the reported accuracy. Some centers claim 20% accuracy by measuring the specific IgE from the nasal mucosa, or even 0%. What we need to know is that the presence of specific IgE alone is not enough for clinical relevance, and therefore these specific IgE can be measured from nasal mucosa after doing a nasal provocation to then in the presence of symptoms. If specific IgE is present, then it can actually be more clinically meaningful for implementing therapies. So this is actually a paper which looked at in patients with allergic rhinitis, non-allergic rhinitis, and controls. They tested the total IgE levels in the nasal secretion and the specific IgE to DP and DF. They found that this was significantly able to differentiate between non-allergic rhinitis and controls prior to testing with nasal provocation in these groups. The variation is huge, and the values are also quite low, so there are no validated cutoffs yet, but something that might come up in the future. We have actually done a similar thing as an experimental scenario in a patient, and we were able to successfully do it. I didn't put that case here because it was purely experimental conditions. Can we use basophil activation test? We actually must have discussed about basophil activation test yesterday. So they have seen that patients who have an allergic rhinitis, local allergic rhinitis, or dual allergic rhinitis, the basophils are the first cells to get exposed to specific IgE. These basophils are not only present in the mucosa, they are also the peripheral basophils are also first target for specific IgE, and therefore they looked at whether basophil activation test from peripheral blood can be checked for in patients with local allergic rhinitis and with DERP1 and DERP2. They found that there was a 50% sensitivity in patients with local allergic rhinitis and dual allergic rhinitis diagnosis. So probably there is a potential role, but it's not yet extensively studied in asthma or in conjunctivitis. Something to look forward in the future with more basophil activation tests down the line. So how do we interpret or integrate all of this into our routine practice? We need to know that we consider local respiratory allergy only when there is absence of SPT, but the classical symptoms are present. Consider provocation testing only in these kind of scenarios to begin with. Have a properly trained center staff and your clinician who's capable of handling the reactions. Then proceed with nasal provocation as a good option because there are now certain validated protocols that are being looked at. There is not much data, but yes, it can be attempted in some patients. You have to choose your allergens which have a therapeutic relevance, particularly to the patient. If alternaria also standardized allergens were there, house dust mite also standardized allergens were there. So we were not sure whether to add a new therapy or to continue the previous therapy. And that was the reason why we actually looked at provocation testing in my case scenario. You can use peak nasal inspiratory flow based protocols, a very simple tool. The more you use it, the more better you start getting at it. It's a very small learning curve. Bronchial provocation test to be done only in reference labs or in complex research settings. Try to withhold yourself from doing if at all you're going to do, you can do methicillin or mannitol, or eucapnic hyperventilation can be done in your setting to identify drop in FEV1. A potential future role I feel that can be used is after provocation, change in pheno, change in oscillometry or nasal cytology can be a few ways to interpret or integrate into your daily practice. So thank you again for the opportunity.
Thank you, Dr. Karthik, for what I could just say. That's absolutely fantastic session. This is a very theory, research-related kind of provocation testing topic, which we all are not so frequently doing, and you have done more than justice to it. Thank you so much. Dr. Karthik, you will be there for the questions in the end? Yes.
Yes, ma'am. Yes, ma'am.
Thank you. Thank you so much. With that, now I invite our next speaker, Dr. Soumya Nagarajan, for her talk. Dr. Soumya Nagarajan has also a pediatric allergist from Bangalore. Ma'am has done the fellowship from Singapore, has also got the Yaki Certificate of Excellence. She has numerous awards. She's the treasurer of the Karnataka State chapter this year. She has numerous papers and publications to her name. With her area of interest, so far I have seen this ma'am is excellent in food allergies, so no one better to take this session on oral food challenges. Over to you, ma'am.
Thank you, Dr. Soundarya, for a very kind introduction and the opportunity from the IAP National Allergy and Applied Immunology chapter for this opportunity, especially Dr. Neeraj Gupta. So after two excellent talks on intradermal testing and the provocation test, going forward with the provocation test, I think the food challenges is also a kind of the provocation test of the food where we are going forward to diagnose or demerit the suspicion of food allergies. So in oral food challenge, generally they serve as the gold standard for diagnosing food allergies across guidelines which say this is the gold standard, and it has certain indications and contraindications. And in the next 15 to 20 minutes, we would like to also emphasize on the structured and safe practical implementation of oral food challenges in clinical practice. Starting off with two case scenarios, which I use commonly in my presentation on OFC. We had this child, 7-year-old, who had vomiting after eating cashew on at 2 years of age and also had hives after eating almonds. However, the mother has been avoiding all nuts, including peanuts, even though there is no clinical history of any reactions with other tree nuts. She is concerned that he is growing older and about avoidance at social gatherings. So what is the way forward for this child? Another adolescent girl with eczema in infancy, she was advised to avoid eggs and peanut because she had secondary infection, the reaction in the form of anaphylaxis to scrambled eggs when young. However, the possibility is that she had bananas also during that time, but she was, however, tolerating banana earlier. She wishes to introduce it back in her diet. So can we help her way forward? So oral food challenge is definitely considered the gold standard for the diagnosis of IgE and non-IgE mediated food allergies. Most of the times, it may be a little impractical for us to do the double-blind placebo-controlled food challenges, which is considered the gold standard actually. So there are ways around which we can probably use oral food challenges for the patients and patient's advantage to increase the array of food what the patient can consume or to diagnose if it is really required. What are the indications which we commonly use for oral food challenges? Confirm suspected allergy when the history and tests are inconclusive. More to the benefit that we should rule out allergy in children with low clinical suspicion but sensitization present on the skin prick test or the serum specific IgEs. We know that the natural history of few food allergies such as milk, egg, have the possibility of children outgrowing by about 3 to 5 years of age in mostly about 70 to 80% of the children to assess the resolution of these known allergies. And also as a part of oral immunotherapy where we treat patients with confirmed IgE-mediated food allergies, we use oral food challenges baseline to evaluate their threshold dose, which determines from where will the patient be starting oral immunotherapy. What are the exclusion criteria? If the patient is having clinically convincing symptoms, what we call within few minutes to 2 to 4 hours where the patient gets reactions in IgE-mediated reactions. If the patient has repeated reactions to the same food, recent anaphylaxis, definitely a big no. Unstable cardiovascular conditions, which is true for all of the atopic conditions. And In selected cases where we have a cutoff value of ImmunoCap results beyond the 95% predicted value, which makes the oral food challenge unnecessary because we know that the patient would definitely react beyond these levels. So I'm not going into these levels because it is beyond the scope of this discussion today. So what are the factors which we need to consider before offering an oral food challenge to the patient? It is always imperative for us to discuss with the patient and the family definitely the risk of a reaction, if small also, that what is the possibility of the reaction and what can be the array of symptoms which can happen during an oral food challenge. Also, it is not that I want to demonstrate what the patient is allergic to. We also have to definitely take into consideration the patient's and the family's preference, especially in a younger child, because the whole point of oral food challenge is if generally we do more oral food challenges to delabel patients with suspected food allergy so that they can start introducing back the food in their diet. And the purpose wouldn't be served at all if the patient has passed the challenge. That means to say there has been no reaction after taking the food, but the patient or the family does not want to introduce into the food. Also, the nutritional importance of a food in question. If a child with suspected food allergies has been avoiding multiple foods and has multiple nutritional deficiencies, I think that also has a major role to be considered when we are offering an oral food challenge. Also, the impact of a positive challenge, if it happens on the patient and the family, because this is a setback for the patient, where even when we insist that if the patient has no sensitization on the skin prick test or a serum specific Ig with very low or no possibility of a reaction to the food, they wouldn't be comfortable doing an oral food challenge subsequently. Patient's medical history, the age of the patient at which the patient had an index reaction, the severity of the past adverse food reactions, and the skin prick test and serum specific Ig of this patient all plays a major role in which food I'm going to choose for oral food challenge and on which day I would suggest. And the speed with which we would be doing an oral food challenge all depends on these factors along with concomitant food allergies. So this was a review paper which was published about 5 years back, but an excellent article which gives an overview about the risk stratification to be considered when one is offering an oral food challenge to patients. Generally, if we consider patients very carefully regarding their age of the patient, the severity of the past reactions, the skin prick test, and concomitant allergic reactions, and we carefully choose our patients. Say in the first group, the possibility randomly when they chose to go ahead and do an oral food challenge without strict risk stratification, they found that the patients with they had the possibility of a failed oral challenges being more and severe allergic reactions also being occurring during the course of a reaction. However, when patients were closely chosen based on very well controlled asthma, probability of the patient having a food allergy based on the history and these reactions and the outgrowing, the patients possibly having a reactions were much lesser when you choose your patients carefully. So the risk assessment also influences the protocol of the oral food challenge. Always have a good control of the concomitant asthma because that is one of the biggest risk factors for a possibility of an anaphylaxis during oral food challenge. And also make sure the patient has no intercurrent illness. Choose to do it in a setting where the possibility of any reaction happening can be well managed. Discuss prior what food you would be doing. Also discuss the number of doses you would be doing. And generally, we discuss with the patient about the steps, what food they would want to eat. We ask them to cook it at home, in what form they would like to continue eating if they pass the challenge. And if I plan to do it in the OPD setting or in the inpatient setting, all that I think makes sense because it influences the protocol of the oral food challenge. Now, coming to few practical aspects in the next few slides. If the patient had an anaphylaxis, just like our first patient we discussed, and the possibility of the clinical history being suggestive of the reaction to the food we are doing, an oral food challenge being very less, and there are no concomitant food allergies or no concomitant atopic diseases or very mild or well controlled, I may choose to do this patient as an outpatient basis. If the patient had a severe anaphylaxis and the possibility of trying to see whether the child is outgrowing the threshold of tolerance we are assessing, then I may choose to do it as an inpatient. So depending on the patient's history, we could decide whether we would do it as an inpatient or as an outpatient in the clinic setup. IV, generally, it used to be done earlier. I'm comfortable doing without IV, though all the medications would be on standby, especially in the setting of oral immunotherapy. If we are doing a baseline oral food challenge, again, depends on the food. Especially, we start off with well-cooked food when we are giving tolerance assessment, where we know that few of the milk or egg proteins are heat labile, and if patient is sensitized to those components, we introduce food in well-cooked forms. So depending on the patient's history, whether we start with well-cooked forms or raw forms also comes into consideration. It is good to have few of the setup where it supports oral food challenge, because it is imperative not only the treating physician or pediatrician is well versed with the protocol. It's important the support team is also well versed to what to expect and monitoring, and even to pick up subtle subjective and objective symptoms, which we will cover later in the next few slides. Always take a informed consent, and it is good to have weighing measuring scales to a microgram and to increase the palatability of the food by heating otherwise. Always have emergency medications on standby for any possible reactions in the form of oral antihistamines, our inhalers, spacers, nebulizations, and if needed, as pediatricians, we all have an emergency cart in our clinic setup. But if I'm trying to do an reaction where we are expecting a reaction, we would do it in an ER setting or a hospital setting with a full crash cart and the team on standby. Generally, we ask the patient to eliminate the suspected foods which we are choosing for the oral food challenge 1 to 2 weeks prior. Generally, I ask for 1 week if the history is not very strong. But if the history is very strong for the diagnosis, probably 2 to 4 weeks they should be avoiding. True holds good for stopping antihistamines for a good appropriate period of time, ranging from 3 to 7 days, depending on the antihistamine the child would have been taking. On the day of admission, make sure the patient generally is without any intercurrent illness or any symptoms of allergic disorders. And we tell them not exactly fasting, to maybe have some minor snacks so that they're not full enough to refuse the food we are giving for the food challenge. And I schedule my oral food challenges generally in the first half of the day. Even if they have any reactions, we can monitor. Informed consent, we have spoken. And I generally ask the parents, if the kids are very young, say about 5 years, 6 years, to get adequate playthings to keep them occupied. We start with minimal doses and increase at a regular interval every 15 to 30 minutes as the patient history and suspicion of the possibility of a reaction which can happen. There is no standard endpoint for the challenge. Generally, it is, we call it as the meal size portion for that particular age of the patient, which I will also cover in one of these slides. Preferably challenge with different foods on different days. So these were the predicted values, 95%, which I was talking earlier, mainly based on the peanut and egg and cow's milk, which is very well standardized, and beyond the cutoff of which oral food challenges, the need to do it is not required. So we have a protocol. Generally, we prepare it in discussion with the family. whether if it is an outgrowing food allergies, we may do it in about 6 steps. If I know that patient may not react well, probably we may do it in 2 to 4 steps. And again, the possibility of the patient not liking the taste of the food is also very commonly seen. And we try to ask them to get some masking agents. It may be applesauce, sometimes Nutella, sometimes peanut butter. They should not have peanut allergy. So something which the patient likes, sometimes curds or sweetened yogurt. So generally, and we label it carefully. And when we are preparing the test doses, we also do them under sterile techniques, especially in the background of oral food challenges when we do. So what is the meal size portion we talk about? So this is taken from one of the the meta-analysis on the oral food challenges, where it's a very nice chart to give us for different age groups. Say they start with 4 to 11 months until about older kids. What is the meal size portion probably for that particular child? And this can act as a guiding point for us to think about an oral food challenge, how we are actually going to go ahead. So when should we be postponing oral food challenge? True to all our provocation tests or allergy investigations, especially if the child is acutely well, having intercurrent illness, uncontrolled asthma, or atopic dermatitis, or if the patient is unable to discontinue medications. Though the theory says that it is double-blind, placebo-controlled food challenge is the gold standard, of late it has been only limited to research settings, and oral food challenge is very commonly used in day-to-day clinical practice, because here the patient as well as the administering pediatrician or the team member would know what the patient is actually being given. So open challenges are very helpful in delabeling food allergies, and sometimes to introduce food which the patient has been avoiding in case of actual food allergies, and for the induction of tolerance also when we are doing. So generally, as I was telling, it depends on the patient's symptoms. We could do 4-dose protocol or a 6-dose protocol depending on the patient. So if it is a 4-dose protocol, I may start off with 1/12 of the dose or 1/8 of the dose, then a little more bigger portion in step 3, and step 4 could be the rest of the serving, which is appropriate meal size portion for that particular child. And if we feel that the patient is going to react or had reaction earlier to that food, I would be a little more careful in going up incremental doses. Sometimes oral food challenges can take any time between 3 to 5 hours, depending on the severity of the reaction, the age of the child, the food in question we are doing for the oral food challenge. So when should we be stopping oral food challenge? Generally, subjective symptoms such as these, if we have urticarial rashes, angioedema, wheezing, any gastrointestinal manifestation, which can actually measure. But subjective symptoms only, where the patient says that I have a mild itching sensation on my hand, but there are no hives visible. But patient is telling that I would have some itching sensation in my throat, but the airway is clear, there is no audible wheeze. I think use clinical judgment. Always use risk-benefit ratio in continuing or stopping oral food challenges. Extend observation period if required before you go on to the next dose. Not only 15 minutes, maybe 30 minutes or a little more longer if you think it is worthwhile going ahead with the next dose of the oral food challenge. Basically, we usually start with a very slow dose and as discussed, and always monitor for objective and subjective symptoms. And we generally have a protocol sheet where what time the patient was administered, what was the dose, and what was the observation. And this is one of the protocols which can be used for oral food challenge, which has all the demographics of the patient. What kind of oral food challenge are we doing? And what is the total dose of food or the weight of food which we are using? And we have any subjective scoring also or objective scoring. Depending on, here it helps as a reckoner for us to document oral food challenges and whether the patient has been passed or failed. So to start, if there was a case scenario, how to assess the oral food challenge? We had a 6-year-old child with outgrowing milk allergy. Oral food challenge was done in hospital to introduce the milk ladder for the first step. The child had urticaria, which was very few with mild abdominal discomfort soon after taking 10 ml of milk. We paused further dosing. Child received a dosing of antihistamine. We continued monitoring. So at least till this step, the child was able to take, and possibly I would stick to the previous step and tell the child to continue taking that amount of milk, that is about 6 ml, until we can re-challenge a child later. So it does help to introduce milk ladder. However, if this patient with another cashew allergies, when we did as a baseline oral food challenge for OIT, the child had, we know that the child would react. So there is no point in pushing the further step of the oral food challenge. Appropriately managed as anaphylaxis. So there is a time where you can actually wait and try to go ahead with the next step of the oral food challenge. If it's a severe reaction, you stop there. So if it's a positive oral food challenge, they would have definitely reproducible objective symptoms. It confirms the diagnosis. But for us, more importantly, it is a negative oral food challenge. It is to reassure the patient, and we encourage them to continue eating that particular food at least 2 to 3 times in their diet every week. It's also important post-oral food challenge, we continue to be in touch with the patient and the family to make sure that they are reintroducing the food. Also, monitor, educate them about delayed reactions also. So we tell them to call us back after 24 hours, or our team members would call them to check they are doing well. And if any delayed reactions also, we give them epinephrine kits, be it auto-injectors or indigenous, with an anaphylaxis action plan as warranted and frequent regular follow. So to finish off the first patient here, we did a skin prick test for other nuts, and except for cashew and almond, the child was negative for peanuts and hazelnut, which we did a oral food challenge on separate days. The child tolerated and is continued taking in his diet. In case 2, the child of eczema where the probability of a reaction to banana was very less. She came to our clinic. We did a skin prick test, was negative. She had a banana in the office challenge and she was fine, and she's continuing to eat banana. So depends on the patient, the risk stratification, the severity, and the supporting medications. So during the process of oral food challenge, always ensure patient safety and protocol adherence. Always plan well ahead how to go about oral food challenge. Be prepared for reactions, and based on a structured history and investigations, choose your patients wisely after discussion with the patient and family how to go forward with the oral food challenge for a suspected food allergen. So thank you for a very patient hearing, and I would be happy to take up any questions.
Thank you, Dr. Samya, for that lovely session. Truly very interesting to hear about oral food challenges and your experiences in it. Since you had said, I said, okay, I will finish off your questions now. Ma'am, what is the, this is just a curiosity from my side. Now, when you had said introduce as well-cooked foods first and then go, is there a possibility where a child has shown a negative food challenge to a well-cooked food and may still react to the raw food? So should we just again like re-challenge or continue the challenge to evolve to the raw food and only then declare negative?
No, I think your question is very valid, Dr. Soundarya. So generally, if the patient has had a negative reaction, that means the patient passed the challenge with no reactions when eating a well-cooked food, they continue taking in that form. But we push the oral food challenge maybe to a later point to the raw food, when the probability of a reaction through supporting skin prick test or a component testing would be very helpful to possibly think that the patient would be able to tolerate in raw form. Until then, we just continue in well-cooked.
One more question. How do you handle these psychological reactions which can be there in little older children? The smaller ones, yes, I agree, we can mask the food.
Correct.
These older children who come, how do we handle that?
Very valid question. So this is the subjective symptoms what we were talking. Generally, as soon as they eat one or second step, they say, I'm not feeling good, I have some itching, or this oral itching is there and I don't want, so we just reassure them, and probably I wouldn't be outright saying that you're allergic or not allergic. I say we will wait and possibly wait for half an hour, 45 minutes, and then still with their consent, go ahead with the next food. I think clinical judgment is definitely important, but I think with careful handling or more time between each steps, we could still possibly do an oral food challenge for that.
Thank you, Dr. Soumya. Thank you so much for that lovely session. Pleasure. Thank you.
Thank you.
Since Dr. Jefferson session will be a little later, Dr. Taha, Dr. Karthik, I will take your questions now. Dr. Taha, you are here?
Yes.
So the question which I have was, what is the role of vaccine testing with intradermal testing? Sir, any thoughts? Can we test
What is the role of?
vaccine allergy testing using intradermal skin test?
Intradermal skin testing in case of people who need
Vaccine
vaccination.
allergy.
Yeah. Not really a great deal of role. Vaccine allergy usually, whenever they happen because of the excipients. Sometimes the diluent, sometimes the preservatives used in vaccine, and most of them are non-IG mediated reactions. There is no harm in doing this testing with 1:10 dilutions. We do it for tetanus toxoid sometimes, but they are just to rule out the IgE mediated reactions if at all they happen. Okay, at least with the skin testing, even Dr. TK last time said doing that would rule out your IgE mediated part. But when it comes to the non-IgE mediated reactions, it would obviously not be ruled out in case of these reactions. There are many drug reactions as well as reactions, especially with vaccines, which are non-IG mediated, and intradermal testing, even skin prick testing, has a limited role in that case.
So one more question. Thank you so much. Can intradermal skin testing also cause sensitization?
Can intradermal test cause new
Cause
sensitivity?
Yes, sir, yes.
Okay,
If
you
you
mean to
skin
say,
prick the
can it be the first exposure to that particular
yes,
agent?
yes, yes.
Not usually. This is seems to be interesting. Theoretically speaking, usually whatever we test the person with, previously we are, by and large exposed to that thing in the form of sometimes the drugs, in the forms of food sometimes, and in different ways. Say if it's an aero allergen, obviously allergens, we are already exposed to those things. I think very rarely this can happen.
My doubt came from, sir, in the hospital, no? We keep
Yeah.
testing for them, ceftriaxone, this, that. Regularly, we do know, so this intradermal testings. So, I had this child who has received ceftriaxone earlier in another
Mhm.
hospital. And after I think 2 or 3 times, child has been admitted in the past. 2 times we received ceftriaxone, 1 time received amoxicillin. But when we tested with ceftriaxone, the child showed reaction. So just to be on the safer side, we didn't give ceftriaxone, of course, because there's always a fear.
Right.
But I was just thinking whether
Yeah.
like that, whether I
You
don't
know,
know,
see, if
not
you have received,
systemic,
if
local reaction, whether
I got it. I got, there are two possibilities, two things to it. One is that if he had received this injection twice before and then, then that time he tolerated that. Then in another subsequent exposure where you tested him, he came out to be skin tested positive. There could be a development of a new allergy. The way, you can develop neosensitization to something. Okay, neosensitization, clinical sensitization, I mean to say, a clinical allergy rather. And then there another possibility is that one is that the other thing is that did you use the right concentration for testing, right dilution for testing? Do you check out? Nurses often
actually,
make mistakes. Nurses
yes,
often
yes,
make
I
mistakes.
understand, sir. That
It
critical
could have been.
concentration.
We need to use the non-irritating concentration. Most of the times, the skin test is positive because of using the because of using the irritating concentration. They give a full dilution, sometimes less dilution. You have to use the right dilution. That could be the reason. I remember, otherwise also it can happen. Sometimes severe allergy can come up when you have used the drug many times in the past. Last year, I got a call from a nearby hospital. There was a lady, young lady, who was polycystic kidney disease, and he received more than 300 meropenem injections in the past on different, more than 300. And on one fine occasion, when she received meropenem, she had a terrible anaphylaxis. And when we were called to that hospital, that time she was on a ventilator. So this can happen. Fortunately, she survived. After 7 days of remaining on ventilator, she could be extubated, but she had a horrible anaphylaxis. This can happen. When a molecule can turn hostile, nobody knows, and nobody knows what's the reason as well.
Thank you, sir. Thank you so very
Thank
much.
you.
Dr. Karthik?
Thank you.
Yes, ma'am.
So, Dr. Karthik, just I wanted to ask, is there a particular ideal time when we should do nasal provocation testing? Any ideal time, like, okay, a child has suffered for this much time, this is not responding, we should wait for, say, how much time? Any timing for ideal for nasal provocation testing?
No, if you're asking me what is the duration of symptoms that when we can start, is that the question about?
Yeah, yes, sir.
Yeah.
Or any
So I think
failure of response or anything.
yeah, normally we label or suspect somebody as having allergic etiology when the symptoms are little longer than your 6 to 8 weeks duration and above. So we generally withhold from testing in only in situations where patients have already been labeled as potential allergic rhinoconjunctivitis or asthma on therapy and not able to achieve a diagnosis. So I think by the time we consider provocation testing, they're a little late in their advanced in their phase at least. So I don't think there is any recommendation as to how soon can we do since symptoms started. But yeah, I mean any situation where you consider the possibilities of an allergic etiology, we should theoretically be possible to do a provocation test.
Thank you, Dr. Karthik. One more question. This is
Yes, ma'am.
just again my curiosity.
Ma'am.
I have children who, the minute I put a nasal spray, itself start sneezing. They sneeze even
Yeah.
with, I think, even saline spray, they will start sneezing. In such
Hmm.
children, no, how do you consider the component of mechanical irritation and
Yeah.
our nasal symptom scoring all will come otherwise, and that whole whatever molecule you put inside will get sneezed out. So, in such children, is this cannot be done?
So that is a concept where we are looking at just like how we have airway hyperresponsiveness, there is a concept called nasal hyperreactivity. So this nasal hyperreactivity is more of a neuronal reflex rather than a mucosal or an anti-Ig, I mean Ig mediated response. So this predominantly falls under the non-allergic rhinitis group. I do have several patients who are allergic rhinitis based on sensitization and their symptoms and their reaction after giving some challenge, but they also have significant trigger related symptoms which are very similar to your allergic rhinitis symptoms like nasal itching, sneezing, which can happen even with just simple saline wash, also produces a lot of sneeze in such patients. So nasal hyperreactivity per se is a very tricky thing. In such patients, I definitely avoid doing nasal provocation because because for the negative control itself, they are going to react. So it will never have a proper objective scoring or a proper differentiation between a negative and a positive challenge at all. So such patients, I will never choose proceeding with nasal provocation.
Thank you, Dr. Karthik. Thank you to all of you. With this, I will proceed with the next and the last session of today. That is by Dr. Jefferson. Dr. Jefferson is an associate professor in pediatric allergy and pulmonology from Christian Medical College, Vellore. And sir has had numerous scholarships and papers and publications to his name. And sir is also doing his PhD. As he's currently unable to give the talk directly, sir has shared his talk with me, which I will be sharing my screen now.
Ma'am, the audio is not coming. I think you're mute, sir.
Dr. Sundarya, the audio is not coming. So you need to change the settings in the audio presentation of yours.
Okay, sir.
So in the Zoom, on the left hand corner in the bottom, there is a button called audio. If you press the arrow of the audio, then you need to select the microphone setting. And in the microphone setting, you need to change the setting so that the audio can come. No, it's still not coming. Try to change once again. Dr. Sundari, audio is not coming. You need to see how it can be done. It is actually the setting of the. Can you hear me? Dr. Sundarya, can you hear me? Sundarya, we cannot hear you. You are not audible, Sundarya. Change the setting again, once again.
Good evening, everyone. My name is Jefferson, and I'm here to talk about drug allergy tests, practical pearls, and precautions. I would like to thank the Indian Academy of Pediatrics, the Allergy and Immunology chapter, and Dr. Neeraj Gupta, especially for this opportunity. And so, what do we have in our toolkit in evaluating drug allergy? We have history, more history, again more history, and some past history. If we can get all these details, that's the best test that we can do. And if needed, we can do a few invasive or non-invasive tests in diagnosing drug allergy. Drug allergy testing is kind of like a high risk, high return field. It's very satisfying, but at the same time, there is a risk to the patient, a risk to us to face legal consequences if patients face undue or unwarranted severe reactions. Sometimes it can be life-threatening. So extreme caution is needed. Our role is very specific. As much as possible, we should do testing to prove that a person is not allergic. If at all we think he is allergic, we should try alternate drugs, or if that drug is absolutely necessary, we should see whether desensitization is feasible. Only if the history is weak, we should test to prove that the person is actually allergic. It's nice to have a group of experienced peers or seniors or mentors with whom we can discuss cases like an MDT meeting. Before testing, it's very important that we discuss with a few colleagues because they may be able to see what we cannot see. This is highly recommended if you're starting to do drug allergy testing. So when we talk about history, what are the questions that are very important? We need to know what is the time frame of the reaction. When was the drug taken? When was the first symptom onset? How long the symptoms persisted? So the time sequence of the events is the most important thing. Second, what kind of cutaneous symptoms occur? Cutaneous symptoms are the most common allergy symptoms to drugs. So we need to know whether it was just urticaria, whether there were wheals, or whether it was a maculopapular rash, whether mucocutaneous symptoms were present, mucosal involvement, angioedema was present or not. So what kind of cutaneous symptoms did the patient develop? What concurrent medicines did the patient take? Very often they take a mixture of medicines, right? Augmentin and paracetamol and ibuprofen. So we need to know what all medicines were taken together. Has it been used in the past? Did the patient react to it in the past? Were there any patient-specific or drug-specific risk factors for a reaction? The patient is an asthmatic. He's already known to have uncontrolled asthma. And after taking a drug, the patient had worsening breathlessness. So is that allergy or is it uncontrolled asthma? Or are they at higher risk for anaphylaxis? And how long ago was the previous reaction if it was present? So these are some of the important historical questions that we need to elicit. Then, based on the history we obtain, it's very vital that we risk stratify these patients into low risk, high risk, or extremely high risk. So somebody who had a childhood rash or the reaction happened many years ago, never happened after that, it was just urticaria, they are low risk people. I mean, you do testing, yeah, maximum they can develop is a rash. And then there are high risk people who have had more than twice reaction to the same drug. That should ring your doorbell. You should be very careful with those patients. Somebody has angioedema, that's again a red flag. We don't want them to have angioedema, vocal cord edema in your OPD or testing area. Anaphylaxis, any anaphylaxis to any drug is a high risk patient. And all this has happened within the 2 years is just increases the risk. And the highest is you are very sure that this patient has anaphylaxis to a drug, but that drug is life-saving and is needed. So that is the highest risk. This risk stratification is very important before testing. So after detailed history taking and detailed risk stratification, then you should choose the best test for the scenario. So if it's anaphylaxis, probably we should monitor the tryptase levels. If it is, just a allergy, either immediate or delayed, we can consider skin test. Intradermal testing, Dr. Taha has spoken extensively about this. Patch testing in terms of contact dermatitis, or graded oral challenge in certain scenarios, extremely low risk scenarios. Don't do graded oral challenge or any provocative drug challenge if the risk is very high. I'm again emphasizing it here. Very often we end up doing a skin prick test or an intradermal test, which are quite easy to do. The only catch here is that you can't test the whole drug. You can't just you buy an IV augmentin solution, take it and do a skin prick test with that, because drugs can cause irritant reactions. That means at a certain concentration, there may be a lot of false positives because some drugs have irritant nature, either the drugs or the constituents. So the European Association and the Network of Drug Allergy, they have established certain concentrations with which you should test so that you don't have a high false positivity rate. Now, this is not available for the Indian population. It could be different, but this is what we have. So each drug has a specific concentration at which it doesn't cause an irritant reaction. And if you're doing skin prick or intradermal, you need to dilute the drug to this particular concentration before you could test. So this is an example of what is a non-irritant concentration for skin prick test, intradermal test, and patch test. See how here it's similar, but in some cases, the intradermal testing dose is slightly a bit diluted compared to the skin prick test dose. And also to note that these are the major and minor determinants of penicillin allergy. So you can't just take augmentin and do a skin prick and intradermal and say, yes, there is penicillin allergy or no, there is penicillin allergy. Amoxicillin is just one component of the penicillin allergy testing kit, which we do not have in India yet. So sometimes when the risk is high or moderate and you really have to test, we kind of dilute it even further. This is a sample testing sheet from CMC that we use. As you can see, there are penicillin G, for example, there are one undiluted skin prick test, and one 1:100, one 1:10. You don't really have to do this way, but if the risk is high, because sometimes people who have strong history can develop anaphylaxis even at a non-irritant concentration, even with the skin prick test. We have had twice such experiences. So sometimes when the risk is very high, you have to test for some reason. It's safer to dilute to 1:100 and then 1:10, and then still negative, you can go for undiluted. But in most low risk cases, you can use the non-irritant concentration straight away. And I wouldn't encourage testing more than one drug in a day. And if you are especially expecting a positive reaction for one of those testing drugs, please always test one drug in a day. Rather than, it's not like your aeroagents where we can prick simultaneously, because any of them can cause a positive reaction. And if there are systemic symptoms, you'll be confused which of these drug caused it. So test one drug at a time. Sometimes one of the common referrals is peri-anesthetic allergic reactions or suspected anaphylaxis, and they need to identify alternate drugs. So this is a sample sheet that we prepared for or a peri-anesthetic panel. See what is the actual concentration of the drug and what is the non-irritant concentration of the drug. And we have to write specific instructions to our nurses or allergy testers how to dilute the drug to achieve that non-irritant concentration. There are, of course, other tests, but each have their own application. Specific IgE is not a very sensitive test, but it can be specific. Unfortunately, it's very sparsely available in India, and very few drugs Fadia and Immunocap have for specific IgE. There are a lot of non-Immunocap or non-Fadia investigations specific IgE. I have no idea about how sensitive and specific they are. Even the best test is only 40 to 50% or even lesser than that sensitive. So they by themselves are not good tests. Skin biopsy, especially if you're suspecting severe cutaneous reactions or delayed hypersensitivity reactions, they may be very helpful. Your basophil activation test is, I think some people are trying to commercially bring it, but it's right now a research tool. And graded oral challenge is very good, but in low risk people, and don't even try this in high risk people. It's going to be troublesome. So there are certain conditions and scenarios where we can use graded oral challenge. And before testing any patient, run through the list of contraindications to drug challenge. It's very important. You don't want to test them with any of these contraindications. Here is a list, a comprehensive list of what tests to use in what scenario. I'm going to leave the slide set with Dr. Neeraj. In the interest of time, I'm not going to go through each, but certain tests have certain applications in certain specific type of hypersensitivity reactions. So this is a summary slide on the sensitivity and specificity of some of the ELISA-based or ELISpot-based blood tests for drug allergy. Just see how low their sensitivity is. These are some individual studies, very few systematic reviews available on the topic, and they are not widely accepted as the first line testing measure yet. But if you do have availability before doing a provocative challenge, you can consider a blood test. It gives you that bit of extra information to decide whether it is worth and safe doing a provocative challenge or not. But they by themselves, along with history, are not enough to rule out allergy. Another thing I would like to address here is test dosing. Things have changed. Things are getting better in India. Previously, when we used to be medical students, we used to give the first dose of antibiotic. Sometimes we will do a intradermal test dose. These things are not proven to work. So even our routine skin prick test and intradermal testing, nobody really knows their sensitivity, specificity. It's very difficult to estimate. So test dosing surely don't work. The only way it can work is you give a fraction of the drug IV, like if you're giving piperacillin tazobactam over 2 hours or 3 hours, you can give 1/10 the dose first, wait, see for half an hour, no reaction, then you can continue the rest. That may work, but any form of intradermal testing, a test dose or a safety check measure, it's not going to work and it's not recommended. Now let's go through a few common scenarios and see how we may choose what test to do. First is a 10-year-old healthy girl who presented to the pediatrics outpatient department with fever, rhinorrhea, and productive cough. There was some sore throat. She's not been eating well. Her older brother recently had similar symptoms but is now improving. She was found to have a bulging left tympanic membrane, erythematous oropharynx with exudate, afebrile right now, and right now the vitals are okay. Her viral testing are negative. Throat culture for streptococcus was sent. Chest X-ray was normal. The pediatric resident labeled her to have an acute otitis media and gave a prescription for amoxicillin clavulanate and discharged the patient. 4 days later, she came back with a diffuse erythematous maculopapular eruption on the face, torso, and extremities. It started 4 days after starting amoxicillin. The oropharyngeal erythema with erythematous lesions on the palate was also seen. So the pediatric allergy registrar saw the patient again and he made a diagnosis of EBV virus related drug rash. So mother wasn't very happy. She said, see, I took the antibiotic and that's when the rash happened. And you are saying it is in virus related drug rash. So should I be worried? Is it safe? Next time, should I take amoxicillin or not? So that's what the mother is asking. So what would you do? So this is a real life scenario. Patients can develop, children can develop drug rash or viral rash, viral exanthems, or drug plus virus combination rash. So how would you manage this patient? What kind of testing you would do? Of course, you would risk stratify. So here it's only a rash, not urticaria. And there was no angioedema, no anaphylaxis, first time, probably low risk. There are certain risk stratification tools also. One is PenFast's tool, specific for penicillin. Probably this is something you can go read up. May not be applicable for every condition, but before doing a oral challenge or a provocative challenge, you can use one of these clinical decision-making rules. Anyway, in our patient, the child had a viral drug interaction. It could have been a viral exanthem, okay, because it happened in a viral infection or it can happen very similar during acute viral symptoms. Starts suddenly, starts in the face, then moves on to the periphery. It's usually not pruritic, not necessarily related to the drug. It's very common. The most common cause of acute urticaria is a viral infection. It could have been a true drug allergy, probably because of the penicillin. Sometimes the delayed rashes can happen 4-5 days later. Okay, this will recur. Third is the viral drug interaction, very common with Epstein-Barr virus. Okay, whenever the patient has an Epstein-Barr virus and amoxicillin, only then the rash develops. Not in other viral infections, not when you take augmentin or amoxicillin for other conditions or when the infection was not present. So that's what the mother is asking. Do I have a true drug allergy or is it a viral drug interaction just like you're saying? How will I know? So in this child, the best thing to do is, because in risk stratification it was low, we can do a direct oral challenge. You can do it graded way. Instead, let's say the child's dose is 250 milligram. You can first give 10 milligram, dilute the syrup, 10 milligram. Then you can probably give 50 milligram, 100 milligram, tolerating half an hour, every half an hour. Then you can give 250 milligram. You just have to be very safe if you want to be safe. Okay. And if you do this drug challenge, when the patient is not having fever, if it is negative, then it is most likely a viral drug interaction or a viral exanthem. If it is positive, the child develops the rash again, then it becomes a true drug allergy. You can also do a skin prick test with amoxicillin and intradermal and review that site after 4 days if there is any positive delayed reaction. Both can be done. Because it is low risk, you can do a oral challenge. Now I'm telling it it sounds very easy when I say, but you have to be very, very careful before doing provocative challenge. Even if it is a low risk, especially when you start, please discuss and then do. So this is a very common scenario. And even if the patient develops a negative oral challenge outside the episode of a fever, you still have to tell the mother, see, it's very difficult to differentiate viral drug interactions, very difficult to prove it. So the next time when you have fever and you take augmentin, there is a chance that the child may still develop rash, because that's like a cofactor. Only when the virus infection is present, the child develops the drug reaction. So it is possible, but be reassured, it is not life-threatening and it is very easily manageable. In the interest of time, we'll go through the next few cases quite quickly. Next is a 7-year-old girl. She develops allergic symptoms, a red rash, and occasional angioedema every time she has a viral infection and has paracetamol. The pediatrician saw the patient and said it could be viral rash. Then the mother says, see, doctor, this happens every time, not just this time. Every time she develops a virus and we give some medicines, she develops it, and I think it could be paracetamol allergy. Is this common? Yes, it's very common. One of the most common pediatric referrals that we get is because of children developing angioedema or rash after paracetamol or NSAIDs. So paracetamol is a weak NSAID, COX-1 inhibitor. So it could be a COX-1 mediated reaction. If it is purely a cutaneous disease, then according to the Yaki classification, it is NSAID exacerbated cutaneous disease. So it could be paracetamol, it could be ibuprofen. So here history taking is very important. Is it happening only with paracetamol, or is it happening with multiple NSAIDs like ibuprofen, mefenamic acid, or whatever we give for fever? History itself will be diagnostic. If it is multiple NSAIDs, then it is NSAID exacerbated cutaneous disease. Some people will have these angioedema and symptoms to NSAIDs, but to paracetamol, they may not have. Sometimes the paracetamol is present half of the time it may not, because it is very dose dependent. At high doses, paracetamol will be a weak COX-1 inhibitor. So sometimes they may tolerate lower doses of paracetamol. So patients will say this particular brand is happening, no issues, but only this particular brand. So it has to do something with dosing. Or it could be some adjuvant allergy also, but in most cases, you do a oral challenge, you will find out. And in children more than 12, there are certain non-selective COX-2 inhibitors which can be prescribed. In children less than 12, it's tricky, and you as pediatricians know the safety profile of COX-2 inhibitors. So I will leave it to your discretion how you manage these. I'll quickly go to my last slide. The third common scenario is patients coming to you into your OPD clinic, let's say severe community acquired pneumonia or a TB meningitis, they're very sick. And then they throw this history that last time I took an antibiotic and the patient developed anaphylaxis. And if you know what antibiotic is that, you can use this cross-reactivity chart between penicillin and cephalosporins. Let's say the patient developed allergy to amoxicillin, and you're not sure what IV antibiotic to give. You can use this cross-reactivity chart and see penicillin, piperacillin. Penicillin G is red in color, so that's not safe. Piperacillin tazobactam is also not safe. But certain higher generation cephalosporins are all green in color, so they are safe. Even that, the chance of a reaction may be less than 1% or 2%. So I would admit that child in an ICU and choose one of those non-reacting cephalosporins and still probably give a small 5% of the drug, wait for 15 minutes. It's not reacting, then probably give 10% of the drug IV, just slow infusion, nothing's happening, and then give the drug full dose. So that's one safe way of handling patients with the prior history of allergy. Another thing you could do is desensitization, but it's extremely risky. People like Dr. Taha has done it extensively. We have done in a few. If you're really pushed against the wall, there are no options. We have done desensitization, but it has to be done in ICU. It's very safe in a sense in the right hands. If you are an experienced team, it is safe. If you're doing it for the first time, I highly recommend you speak to Dr. Taha, and or you can contact us. We can help you. So with that, I will close my presentation and open for discussion. Sorry, I took a few minutes extra. Good evening.
Thank you, Dr. Jefferson, for sharing that video with us. With that, I would like to conclude this session. This has been an extremely interesting session on investigations in allergy practice, and all our eminent speakers have been really very, very kind for sharing such lovely snippets of knowledge from their vast experience. So thank you to you all. Dr. Neeraj, any word of thanks from you?
So thank you, Dr. Soundarya, for the wonderful moderation. And I must say that today's sessions, all the 4 sessions, starting with intradermal testing by Dr. Taha, followed by Dr. Karthik, some practical insights for the less used tests like nasal provocation, bronchial challenge. So all these things are not very well understood, very well used, especially intradermal and all these things. And then Dr. Somya, oral food challenge, and then now Dr. Jefferson about the drug allergy testing. So all these are not that commonly used, that commonly practiced, and they are much more riskier but safer in the expert hands. And you all have really done a fantastic job, wonderful job today. So thank you so much for all your wonderful collaborations and contributions. And with this, we come to the end of this webinar series, which is on allergy investigations. I would request every one of you who are interested in learning more, so they can once again go back to our YouTube channel, and then they can just access this webinar series. So, and once again, excellent moderation by Dr. Soundarya, as always. So thank you everyone. Have a great day. Thank you.
Thank you, sir.